So it is my pleasure to introduce our next speaker, Jessica Geiger. So Dr. Geiger is an expert in metastatic squamous cell carcinoma. She has done trials and published in squamous cell carcinoma. She is our director of head and neck oncology and the vice chair in the Department of Hematology Oncology. She's a fantastic colleague. It is really my pleasure to introduce her. And we'll hear a whole lot more about the cool new treatments in skin cancer. So her talk is entitled Metastatic Skin Cancer Treatment Now and the Future.
Great. Thank you. I'm going to share my slides here. As I get them pulled up, I just want to make a comment. As Dr. Fonchain said, I primarily treat head and neck cancer, and I've had the distinct privilege of, over the last 7+ years of my career since being a fellow and advanced training in oncology, really seeing the changing field of non-melanoma skin cancer. So I don't treat melanoma, I treat mainly head and neck cancer. And historically, the purview was that these advanced non-melanoma skin cancers sort of fell to the head and neck medical oncologist because, as you heard from Dr. Arversman and Dr. Vitamos, a lot of these really advanced, the really aggressive disease that's not cured by simple resection or resection followed by radiation fall on the head and neck. And so just naturally it gravitated toward head and neck oncologists. Just a note, I'm not going to talk about basal cell. Immunotherapy does work for basal cell, and cemiplimab is approved for that, but I'm going to mainly focus on advanced cutaneous disease because that's really where we've seen the increase in numbers, and largely it's related to immunosuppression, whether through organ transplants or through autoimmune disorders on chronic immunosuppression, and so I'll touch a little bit on those. Immunotherapy is really a mainstay now in advanced cutaneous squamous cell carcinoma, and it shouldn't be a surprise. We're not surprised by this because even years and years ago, before immunotherapy was approved in this disease, there are many factors that support the use of immunotherapy or immune checkpoint inhibitors. High mutational burden in these disease, the presence of what we call TILs. So we have these lymphocytes or these immune cells that are infiltrating the cancer more so than other cancers. We know that immunosuppression is a risk factor, and the immunosuppressive effects of UV radiation, and also early clinical efficacy with medications like interferon and cetuximab that I'll talk about in a bit. So currently approved therapies, and again, I appreciate my colleagues in kind of laying the background and the groundwork of who's at risk for this disease and what does it look like. Cemiplimab was the first immune checkpoint inhibitor, PD-1 inhibitor, that was approved in 2018, Pembrolizumab a couple of years later in 2020, and both of these are approved for, quote, the label indicates locally advanced or metastatic disease that's not amenable to resection or radiotherapy. Resection, radiotherapy, those are what are considered curative-based treatments. So this is considered palliative intention, meaning that our goal is not to cure, but rather control. However, over the years, we have seen long-term complete responses to this treatment. And so I and others are confident and convinced that we are curing a handful, more than a handful of patients, a great deal of patients, but time will tell exactly how many patients there are. And as we gain experience and just time, we are more confident about this. So as a medical oncologist, everything that we do is based in data and clinical trials. And so I have speckled throughout my presentation tonight some really boring slides of survival curves and things like that. So I'll throw these up here, but I will explain it to you like I explain it to my patients sitting across from me in clinic. This is the first initial studies with cemiplimab back in 2015, 2016 that led to the approval in 2018. And as you can see here circled, what we call objective response rates. That's oncology speak for how many patients did the tumor shrink. And so you can see really high numbers. And this was really evident that this is a very different disease than head and neck cancer. So even though they're both called squamous cell carcinoma, whether it occurs on the cutaneous part, your skin, or whether it occurs on the wet part of your upper aerodigestive tract, they're very, very different diseases, and we should not be treating them the same. So this is the results of the phase 2. This is called a waterfall plot at the top. And what you want to see are a lot of patients. Each bar is an individual patient. And so the vast majority of patients their tumors are shrinking. And this is the degree of shrinkage of their tumor. You still see some progressive disease here. So it's important, I tell my patients, this treatment doesn't work for everyone. Immunotherapy does not work for every patient with advanced skin cancer, but it works for a lot of them. And it's very well tolerated. And so unlike before, where all we had was traditional cytotoxic chemotherapy that didn't work very well and came with a whole host of side effects and toxicities, the tables are in favor of trialing treatment in these patients. What we test for in other diseases is something called PD-L1. This may or may not be considered positive in skin cancer. And it doesn't really matter because while the studies show that if you're PD-L1 positive, you're more likely to have a response, it's not a perfect marker. And that was all that is indicating. These are survival curves from the Pembrolizumab monotherapy studies, but very similar to the cemiplimab studies. So what you're seeing are these good responses in this tail end of the curve, which is what we always talk about for almost every cancer that's treated successfully with immunotherapy. Again, the idea is that it doesn't work for every patient, but those patients who do have a benefit to immunotherapy, this benefit can be long lasting for months and months and years and years and years. And this is what we're seeing with these trials. So standard immunotherapy for advanced cutaneous squamous cell carcinoma, there's 2 anti-PD-1 inhibitors, pembrolizumab and cemiplimab, and they're approved as monotherapy, so alone agents to treat locally advanced or metastatic disease that's not curable or amenable to resection, whether it's Mohs resection or a larger resection, or radiotherapy, or in patients who are not candidates for these treatments. Dr. Venemo's put up examples of a 100-year-old, 104-year-old, which is good, but sometimes, such extensive resections involve general anesthesia, and medically, advanced age, the patients just may not be candidates for surgery. And so that's an indication to give immunotherapy a try. So what do we do when and if immunotherapy doesn't work? Cetuximab is a targeted agent. It's not considered chemotherapy, but there's phase 2 data that supports this. And I use this regularly in many patients. We still have traditional chemotherapy. It doesn't work well. It's a lot of side effects. So the bottom line is if patients don't do well with immunotherapy, we have some options. They're not great. And I'm seeing patients who are dying of this disease. And so we're really trying to get clinical trials, whether it's immunotherapy combination or novel agents. We have a couple of studies currently open at Cleveland Clinic where we're trying to utilize and capture these patients who are not doing well. Again, the vast majority of patients have a benefit to standard of care immunotherapy, but not everyone. And so it's a great clinical unmet need. How do we move these medicines into the curative setting? So the current standard treatment, and no matter what, of even advanced cutaneous squamous cell cancer is resection followed by radiation therapy, or sometimes radiation therapy alone. What we know is based on limited prospective studies, there's no added benefit with adding chemotherapy called a radiosensitizer to post-op radiation. Again, this is different from our treatment paradigms or our standard treatments for traditional head and neck cancer. But because we know there's high response rates to immunotherapy, the question is, can we use this in the curative setting? This is just one of the most recent, largest phase 3 randomized studies. Basically, what you need to know with this slide is we added chemotherapy to standard post-op radiation, and there was no benefit. So there was toxicities, but no survival benefit. And so even though this was the first reported trial, what we concluded from this large study was that overall survival outcomes in this patient, a very high-risk disease, were good, and it didn't make a difference with adding chemotherapy. So that's not the current standard of care. However, we can learn from this study, like we always do, even in negative studies, that, first of all, the question is high-risk population. There are certain features that we who treat this cancer on a regular basis know are going to lead to higher risk disease. Lymphovascular invasion. That means the cancer is breaking out of where it started. It's getting into the blood blood vessels, it's getting into the lymphatic system. Satellitosis is a fancy word to say you have your primary skin cancer here, but you're popping up in other areas. Very high risk disease that's not even captured by our standard staging systems. So can we identify higher risk patients who are more likely to benefit from such treatment? Immunosuppressed patients are often excluded from clinical trials in skin cancer. And this is really a shame because these immunosuppressed patients have the highest risk disease and they're the most likely to have bad outcomes. And then the chemotherapy choice. So this is just a slide for 2 adjuvant therapy, national large randomized phase 3 studies that are ongoing. Keynote 630 is utilizing Pembrolizumab. It's randomizing Pembrolizumab to a placebo. Again, for both studies, this is locally advanced high-risk disease that's been surgically resected, followed by standard post-op radiation, and then patients are randomized either to Pembrolizumab or Cemiplimab, depending on what trial it is, versus placebo. And we have these studies open at our institution. We eagerly await these results. We know that they're going to be good. We've had some preliminary analyses and the studies are still ongoing. More exciting and more recently is, can we use a neoadjuvant or a preoperative setting for immunotherapy? And the rationale for this, again, most of these cancers are going to be on the head and neck area. The head and neck is a very small area. There's a lot of precious real estate is what I describe to patients. So it's not just, like an arm or a leg or your chest or your back where you can kind of scoop out disease. I'm not a surgeon, so I'm not going to be as eloquent in speaking about this like Dr. Vidamos. Can't just scoop out the disease when there's a lot of vessels and nerves in your eyeballs and, your windpipe and all of this involved. And so if you can downstage or shrink down the cancer, can that impact the surgical plan? Functionally, are functional concerns, are you able to salvage an eye that otherwise would have to be sacrificed in a surgery? Cosmetic concerns, of course. Can it impact the adjuvant plan? Do we need radiation, which has a whole host of side effects and problems in and of itself? And ultimately, as our goal always is in cancer clinical trials and in cancer care, is can we improve overall survival and other outcomes? So just quickly, 2 studies. This was a pilot study run by Dr. Neil Gross at MD Anderson in Texas. So 20 patients, they were treated with a couple of cycles of Cemiplimab immunotherapy up front prior to surgical resection. And again, you can see a waterfall plot here. I have my cursor pointing over to the patients who had a tremendous response to just 2 cycles of immunotherapy. And what was important was out of the 20 patients who were treated with 2 cycles of Cemiplimab, 17 of them had such a significant shrinkage of their tumor. If they had a complete response, which 11 of them did, they didn't even need radiation after it, and there were 0 recurrences. So this led the foundation for a national trial of about 80 patients. We were involved in this as well. The vast majority of tumors were in the head and neck area. Again, patients were treated with either 2 or anywhere from 2 to 4 doses of Cemiplimab, and then they underwent surgical resection. And this was just published within the last year in one of our major journals. Again, you can see the vast majority of patients had such a significant response to that. So this is not standard of care. I would implore, this is not, this hasn't changed our management, but this has initiated a lot of discussions and a lot of conversations that we have with our multidisciplinary non-melanoma skin cancer of, a patient who normally would 5 years go straight to surgery and maybe have, a major surgery with reconstruction and a lot of healing issues, followed by radiation. And they are cured of their disease, but can we give a little bit of immunotherapy and spare them surgical complications or spare them radiation complications? And so these are conversations that we have on a regular basis within our multidisciplinary group. Further investigation is warranted both in the adjuvant and preoperative setting, as I had mentioned, and we need to consider a lot of patient selection, therapy duration, all of this, again, conversations that we have regularly at our institution multidisciplinary setting. So just a couple of cases here. These are all of my patients. that I'm presenting just a very small snapshot of them. So this was a lady who was surgically resectable. She was in her late 70s and she was otherwise healthy. However, surgery would have likely involved removing her left eye. So again, when you're doing a cancer-directed surgery, the goal is to get all of the cancer that you can see out. And that would involve taking her left eye. She is severely vision impaired in her right eye from retinal detachment. So for her to stay independent, she had to maintain her eyesight. And so she refused surgery. You can see the improvement that we had just after 2 doses of cemiplimab. This was after the last screen is after 7 months. We usually treat between 1 and 2 years. That's, again, the best clinical trial data that we have. She herself, very strong personality. And after about 9 or 10 months of treatment, she said she was done with coming into the clinic and she would follow up with me every so often with scans. I just saw her within the last month or 2, clean scans, no problem whatsoever. And she's been off treatment for about 3.5 years. Again, this is another patient of mine who, an avid golfer in his 80s. Surgery for this would have clearly involved taking the eye that you can see here on MRI, where right here, where I'm circling, is his above eye recurrence where he had, involving the extraocular muscles here. So the eye would have had to go. He didn't want to do that. His vision was important to him. You can see we treated with just after 3 cycles of pembrolizumab, he had a significant response. I treated him for 2 years as standard. Imaging was all stable after that. I just saw him in clinic within the last couple of weeks. He celebrated his 90th birthday. I treated him off-label with Pembro at this time because it wasn't approved. So we got off-label use for it. What's interesting about this, and I have to make a plug here, while he was on immunotherapy and having such a great response to this skin cancer, this advanced skin cancer, he developed another completely unrelated cancer. So that is just my plug to say that even though immunotherapy can work really, really well for these really advanced cases, you can still pop up with even less invasive skin cancers. So I always tell my patients, even though we're embarking on this course of immunotherapy for your skin cancer, you can still have little skin cancers that pop up that you need to see your dermatologist regularly for every 3 to 6 months. And I fully support any Mohs procedure, any cryoablation, anything like that to get rid of those while we continue with immunotherapy. So immunotherapy can work really well for the big, bad, ugly ones, not so much for the little ones. And still the dermatologist plays an integral role there. My last patient case here, this was one of my more recent ones, very rapidly progressive nodule on the back of the neck there. She also had some lymph nodes under her armpit on the right side that were involved with this cancer. You can see just by the dates above the rapid progression that she was having. Very painful, very inflamed, very ugly. When I initially met her here, I saw her back the following week to start cycle 1 of cemiplimab. And this is what the change was in just 1 week. This is when I saw her for cycle 2. So from here to here, the second to the third frame, that's just with 1 cycle of immunotherapy. So very dramatic results here. I'm over time, so I'm just in my last few slides just going to again reiterate organ transplant patients who are on chronic immunosuppression have really, really bad disease, and we don't have great options. We know that the type of immunosuppression, especially for renal transplant patients or other transplant patients, is important. We, again, work multidisciplinary very closely with our transplant physicians and surgeons to try to minimize or to lessen the chronic immunosuppression. Rheumatologists, gastroenterologists, no matter what the autoimmune disorder is, to try to minimize that or to reduce it as much as possible, because we know even just decreasing the immunosuppressant doses can help the cancers. And these patients are dying of these cancers. This is just to show you that we can use immunotherapy in transplant patients or autoimmune, chronic immunosuppressed patients, but it's not without risk. And the risk is flaring autoimmune disease. The risk is rejecting your transplant. So it's not something to take lightly. These are conversations that we have very extensively with our patients so that the risks are known. And there's just exciting studies that are coming out using immunotherapy, but also using as a standard approach different prophylactic steroid regimens, different prophylactic kind of immunosuppressant regimens to minimize the risk of transplant rejection while optimizing the benefit of immunotherapy. So in conclusion, PD-1 PD-1 inhibitors, immunotherapy approved for advanced disease that is non-amenable to resection or radiation, although we have conversations of whether or not it could be used in place of surgical resection. Number two, we are trying different clinical trials to bring this into the curative setting, both adjuvant and preoperative setting. And again, just to highlight an unmet need for both immunotherapy failures, as well as all patients with chronic immunosuppression for whatever reason. We need to devote time and energy and resources into clinical trials for these patients. Thank you for your time. And I think we will go right soon into the Q&A. Let me stop sharing here.
So there are a lot of fantastic questions in the Q&A. Hold on tight. Thank you so much, Dr. Geiger. That was an amazing talk. Great patient stories. We always love hearing those.